GLP-1 of liraglutide. And what it shows that there are only 52 patients published in Lancet about 3 years back that, NASH resolution, that, you have improvement in inflammation and the NASH went away, was seen in 39% patient in liraglutide versus only 9%. So this is a very powerful, but there are a lot of interesting new GLP compounds, which I think that may be one of the future, because this is a compound now been associated with long-term survival in diabetic, and so this has to be taken into account. So I still believe some kind of a GLP will be in the armamentarium of NASH patients in the future. So let's talk about the emerging therapies and where we are right now. So before we talk about, there will be a lot of studies already published. There will be a lot of new studies will be coming on. So you need to understand that what criteria or endpoint they're using it to, so before you get. So in phase 2 clinical trial, what the FDA want that you can show the improvement of ALT and this MRI fat fraction that we call, that you can have a 5% absolute reduction or greater than 30% relative reduction. So if you can show that in a phase 2 clinical trial that your medication can achieve, that you don't need to have a histology and you can potentially go into the phase 3 clinical trial. The next is the phase 3, which is a main. But in any of the new medication of NASH that will be approved in phase 3, you need to have a histological improvement. And how they define it is the NASH resolution, which is basically your inflammation goes away and the NASH goes away with no worsening of fibrosis. So that is one of the endpoints. And the second endpoint is the fibrosis improvement, that you have improvement of greater than 1 stage of fibrosis with no worsening of steatohepatitis. So if your medication can prove it that you can do it, you would be eligible to get an FDA approval, and that's what the medications look like in the future. So there are many phase 3 clinical trials, but there are 3 which I think were very important, and I'll go over a few of them. One is the elafibranor. The second is obeticholic acid, which is now very close to get an FDA approval. Silonsertib, and then Sensiboric. So these are the 4 important phase 3 clinical trials using more or less the same primary endpoint. However, we know that the silonsertib, which is the ASK1 inhibitor, which has from Gilead, got a lot of publicity, but the trial was a negative trial. So they spent billions of dollars, now this medication is out. And we will see a lot of these medications which have a lot of promise, but it's going to go away in the future. So this is out of the picture now. Dr. Saleh already talked about a good FXR pathway. So the first thing is the medication I want to talk about is obeticholic acid. So in a phase 2 clinical trial, which we call the FLINT, the primary outcome was improvement in NAFLD score with no worsening of fibrosis. So in the phase 2 clinical trial, our study shows that 46% patients who were on obeticholic acid, 25 milligram, versus 21% had a response. So this was statistically significant, and also there was like improvement in fibrosis. Also, patient had improvement in ALT, also lost weight. So this was the main reason that medication was approved to go into the phase 3. So in the last year and early this year, they have started giving the early preliminary analysis of their data. This study, which called Regenerate, it was a large study, international double-blind randomized controlled trial. And there are 3 arms in this study. One is obeticholic acid 10 milligram, which have 312 patients, obeticholic acid 25 milligram with 308, and placebo, which is 311. All the patients had biopsies and they had fibrosis, and this was the data on stage 2 and 3 fibrosis, and the NAFLD fibrosis score was greater than 4. There still is an ongoing clinical trial, and the target is about 2,400 patients. So this was 3-arm study, 10 milligram, 25, and placebo. So this is the data, latest data, and this is actually, I just saw that yesterday, this finally the publication got accepted in the Lancet, and it will be getting online in the next day or 2. So you can actually read this interim analysis of it. So if you see that 11% or I would say 12% patient in the placebo had improvement in fibrosis as compared to 23% in obeticholic acid. So now it's important. When you look at the clinical trials, it's all about statistics. You can prove that this medication is better. But if I were a patient, I am in Pakistan, I think that in a placebo, patients having a 12% improvement, right? And the medication, which may be like thousands and thousands of dollars in America, it's a 23% improvement. So whether that would be worth or not, so we still not that good 23% improvement in fibrosis only right now. But if you look at it in another way, that 25 milligram of obeticholic acid, so in green, that how many patients have improvement in fibrosis versus worsening fibrosis as compared to placebo. So 38% overall had some improvement in fibrosis and 13% had worsening. So these patients with NASH, they don't have liver specific, they have diabetes, they have risk of cardiovascular, they have hyperlipidemia. So any medication which will be approved, we don't know how long this medication will be used and what will be other long-term effect. So if you look at this trial, this was just, Arun, this presented there some adverse effect of this trial at ASLD. So the one thing is that this medication in Flint trial and also in this does increase the level of LDL, right? And then according to them that if you start statin that you have an improvement. And the biggest thing which I think, which is also from PBC, that 51% patient had pruritus. And this was, we saw it in the Flint, although the company says that it can be easily be treated, but the compliance would be a big issue, and this pruritus is not a favorable. I feel that patients just not take the medication. So this is the thing we have to look out for. But what it is that this will likely be the first FDA approved medication by that, for NASH, because they're already in the pathway, and our feeling is in the next 3 to 6 years that this medication will be approved by FDA. So look out for it. This is a very interesting new compound, FGF19, which is NGM282, which again, it's an FXR pathway, and they are in a phase 3 clinical trial. So this was the data from last year of their patients. And I wanted to show in the absolute reduction in the fat content. So there were 3 milligram and 1 milligram arm. So it did show significant improvement, and this was the reason this medication. Because I still believe that we have very new FXR agent which will be very specific with very limited effect on the liver, and this may be one of those. So FXR will be the backbone or one of the backbone of the future medication approval for NASH. Now this is another compound that is in the phase 3 called elafibranor, which is the dual PPR alpha and delta agonist. So how does the PPR actually work? So alpha component decrease the fatty acid oxidation, decrease the triglyceride, increase HDL and inflammation, and delta does do the lipoprotein metabolism, glucose homeostasis, energy metabolism, and inflammation. So if you look at the phase 2 clinical trial, which was published about 3 years back, that they had one very impressive, when they wanted to have a clinical trial, they have a very extensive goal. Their primary outcome is that not only patients will have an improvement in NASH, they should have no worsening of fibrosis and no worsening to stage 3. But if you look at the protocol defined outcome, on the left, there was no significant difference. In between the clinical trial, they modified the definition that there should be no worsening of fibrosis. And once they did that, 19% versus 12% had improvement. It wasn't a huge improvement, but that led them to start the phase 3 clinical trial, which is at the end of the enrollment. We don't have any preliminary data, but this is the second medication which we'll be hearing more about it. So, as I was telling, now I'm going to show you some updated data from the latest ASLD. PPR is a very interesting compound, and I still, because of its effect in decreasing hemoglobin A1C and cholesterol, this may be one of those compounds that we will be. So the latest compound is saroglitazar, which is a simple name is Saro. It's a novel regulator of lipid and glucose. They present the data of phase 2 trial, and they have 106 patients of 1 milligram, 2 and 4. What it shows that overall you have improvement in the percentage improvement in ALT in 4 milligram, and also have improvement in fat fraction. Very early data, but based on this data, they are planning to go into the phase 3. So this will be the other compound to look out for. VK2809, it's a very interesting concept. It's a thyroid receptor beta agonist. And this is a different pathways, improve the inflammation, and this was also the data from last year, and they are now starting the phase 3 clinical trial. It does decreases the change in LDL, but mostly if you look at that, there's a significant change in the mean absolute change in the liver fat fraction at 12 weeks. And this was also very powerful. There's a decrease in LDL, improvement in fat, so I think that would be another interesting. They didn't have significant side effects, so I also like this compound, and I think that may be some of the future. And don't buy stock for any of these agents based on my information. Do your own research, but there are a lot of other things that are very interesting. So just trying to tell you one story. This was also from ASLD. So emrisakan, which is an oral pan-caspase inhibitor, had a lot of publicity in 2018. They did a late breaker abstract, shows there's an improvement in fibrosis, and they did their preliminary data. But finally, when the trial ended, it basically shows that it did not improve fibrosis with NASH. So this compound is dead now. And again, there was a lot of promise in 2018, but when the final thing comes out, it actually shows in the placebo and it actually sees that you have worsening in emrisakan arm, which is 41 as compared to placebo. So there was no improvement in fibrosis or NASH. Lastly, I just wanted to make sure to tell you something different and something which is not medication. So this is a very interesting concept. There is a company which has this device, an endoscopic device, which you call duodenal mucosal resurfacing, or DMR. It's a 45-minute procedure according to them. It's not available in the US, but there is in Europe, and they did a study. So this was a late breaker which Arun presented, and it is being like, what they show that it's a resurfacing and it's a minimally invasive that, basically you align the duodenal mucosa and change the metabolic pathways. And they saw that there was improvement in type 2 diabetes and concomitant fatty liver disease. It's a double-blind sham study. The patient didn't know which procedure, and one-on-one with type 2 diabetes. And it did show that the DMR had improvement in the fat fraction and lowering A1C. They're doing other studies in diabetics, so look out for this thing. I think that may be some of the future, or maybe, so we need to think out of the box. So I just wanted to mention it so you hear about it. So lastly, I just wanted to show you what we have available, right? And then improvement in fibrosis will be important. So this is not a head-to-head comparison of the studies, but just give you an idea that how many, in the different studies, how much improvement in fibrosis does happen. So in bariatric surgery, if you have a weight loss surgery, 34% improvement. So these two agents, which are very popular in the phase 3 clinical trial, you say there's a 35% improvement as compared to 19 versus 20 to 10%. But I just wanted to pay you attention about vitamin E. So vitamin E, when we did the study, the outcome was NASH improvement. It was not tapered towards that, whether it was not, the endpoint was not fibrosis, the study was not long enough. But even then, we have seen 41% patient had improvement in fibrosis. So the question is whether we need to get a bigger trial to show, because vitamin E is a supplement, it's still cheap, and so I think that we have to be not on the bandwagon for all these medications. We need to keep thinking about obesity, diabetes, and if there's other alternative. And I think Pakistan will be the place that you can do a very amazing vitamin E study, biopsy proven, and can show, because we have tons of patients and you just have to have a good clinical trial. So in summary, obesity and lifestyle modification is the key. Vitamin E still is the main treatment, at least for us in the US, especially at UCSF for biopsy-proven NASH. They're very exciting molecules in the clinical development and treatment of NASH and hepatic fibrosis. Although there is no FDA-approved therapy, but obeticholic acid will likely be approved in the next few months. But the key would be, even if a medication will be approved, which patients will need treatment, how long the patient will need to be on treatment, and what are the side effects, and what will be the long term. So these are more questions that we will need to be answered even when you have medications would be available. So this is it for me, and thank you, everyone.
Thank you very much, Dr. Bilal, creating a lot of hope in the future. for the treatment of NASH. A few quick question answers. Okay. There is no time for the question answers.
I want to ask one comment or one question from Dr. Bilal Hamid. Very nice presentation. There are very few drugs available for the treatment of NAFLD and NASH. You told, and the diet and exercise is the main thing. And you told about the vitamin E. So what would you say about the role of vitamin E in NASH and diabetics and in the non-proven NASH without this liver biopsy, non-biopsy proven NASH?
Hello. So the first question is role of vitamin E in diabetic patient. Our PIVENS trial did not include diabetic, but then we had other studies. There are a lot of studies that had been done, the clinical trials which allowed patients to get vitamin E. So we have enough data on vitamin E in diabetic that it's safe. And the issue with vitamin E is that what dose was safe, right? So if it's 800 or higher dose was associated with some risk of hemorrhagic shock and some other platelet aggregation. There was some paper from shows that increased risk of prostate cancer, but that's not consistently been shown. So vitamin E is safe, and also, so I would, now the question is, we can do a biopsy. If there is a group, and especially people in patients like in Pakistan, so I would say that if someone has an elevated ALT, and if you have some concern about, you can give it a trial of vitamin E because it only works in 46%. And if the patient does have improvement in ALT, you can actually stop it. In America, we do, because what happened when the study came out, anyone who had steatosis on the ultrasound was started on vitamin E. So that I would avoid. So you can come up with your own algorithm that this may be the group of patients that maybe we should try, give it a trial and see what happens. But you should talk to the patient that this is evidence, and this is what I'm doing. Thank you.
Okay. Okay, so we close this session. Thank you very much.
I'm sure there are a lot of more questions about NASH, but we're going to have a workshop on NASH in the Quetta boardroom, and Bilal Hamid is part of the team who's going to answer your questions there, so you can ask your questions there. We have concerns about time, there's a shortage of it, so we're proceeding straight to the boardrooms, which is down this hall, a little left, and then up the stairs, and there are 4 boardrooms there. We have the pregnancy-related diseases in the Faisalabad boardroom. We have the NASH in the Quetta boardroom. In Gulbit boardroom, we have the HCV diagnosis and treatment, and in the Gilgit boardroom, we'll have MDT for HCC. So I'll request you to please move to the boardrooms. The lunch will be served, working lunch will be served in the boardrooms, and no lunch will be served here. The lunch will be in the boardrooms, and you will have to go there to get your lunch also. So please, thank you very much. Thank you very much.
Thank you, Dr. John.
Thank you. You are the key person. He is the key person. You should know him. He is not his key person. Thank you very much. Nice meeting you.
जरा सी मियाँ की तस्वीर देखिए, मैं आपके साथ तस्वीर देखी हूँ, मेरे साथ ना तो जरा तरीके से नहीं होगा ना भाई ना कि ये सारे के इन्होंने फोन किया वीडियो कॉल कितना सी जा रहे हैं, मैंने कहा सर लैपटॉप चुक ली अभी माइक बंद कर यार अभी माइक अरे यार किया सर ओहो मैं वो तो पूछ रहा हूँ कि भाई ने किया था मुझे वो उन्होंने किया था इधर आ पर समान लपेटा काम पा दो भेड़ लेने ना यार भेड़ लेने काम